Hi, I'm Professor Nadia Harbeck, and I'm the Director of the Breast Center at the Department of Obstetrics and Gynecology of the LMU University Hospital in Munich, Germany. I'm also a full professor for conservative oncology at the Department of Obstetrics and Gynecology at the Ludwig-Maximilians University in Munich. Thanks for joining me as I discuss recent follow-up data on CDK4/6 inhibitor and what impact the results are having on clinical practice. Approximately 20% of patients with hormone receptor positive, HER2-negative early breast cancer experience disease recurrence within the first 10 years. As such, CDK4/6 inhibitors are being investigated in adult patients with hormone receptor positive, HER2-negative early breast cancer with a high risk of recurrence. 2 of them have shown positive results in early breast cancer, abemaciclib in monarch-E and ribociclib in NATALEE. You can learn about the phase 3 monarch-E trial in our previous video. There's a link in the description below. In the phase 3 NATALEE trial, adjuvant ribociclib and endocrine therapy was evaluated versus endocrine therapy alone in a broad population of patients with stage 2 or 3 hormone receptor positive, HER2-negative early breast cancer at risk of recurrence, including patients with no nodal involvement. Ribociclib plus endocrine therapy demonstrated a statistically significant, clinically meaningful improvement in IDFS with a well-tolerated safety profile. Despite these promising results, there are unanswered questions about the use of CDK4/6 inhibitors in node-positive early breast cancer patients at high risk of recurrence. 3 important questions are whether the benefit of a CDK4/6 inhibitor persists beyond the treatment period, does Ki-67 predict CDK4/6 inhibitor benefit, and whether premenopausal patients also benefit from a CDK4/6 inhibitor in the early breast cancer setting. The NATALEE trial has so far only shown very early follow-up data with 80% of patients still on treatment. Instead, with a longer follow-up, which already reaches beyond the actual treatment period, monarch-E can provide answers to all of these questions. Let's take a look. In 2023, Professor Stephen Johnson and colleagues published updated efficacy outcomes from monarch-E with a median follow-up of 42 months. This was a pre-planned analysis that was part of the original monarch-E study design. monarch-E recruited 5,637 patients with high-risk hormone receptor positive, HER2-negative early breast cancer who were randomly assigned to receive their physician's choice of standard of care endocrine therapy for up to 10 years with or without abemaciclib 150 milligrams orally twice a day for 2 years. This pre-specified interim analysis occurred 2 years after the primary outcome analysis. The primary endpoint was invasive disease-free survival, or IDFS, in the intention to treat population. The curve we see here shows us for the first time results beyond the actual treatment period. For IDFS in the intent to treat population, we can see an absolute improvement of 6.4% at 4 years, with 85.8% of the patients being invasive disease-free when treated with endocrine therapy plus abemaciclib, compared to only 79.4% of those treated with endocrine therapy alone. The hazard ratio was 0.664. For overall survival, the data are still immature, but at 4 years, 5.6% of the abemaciclib plus endocrine therapy group had died compared to 6.1% of the group given endocrine therapy alone. The hazard ratio was 0.929. In terms of safety, this was consistent with the known risk profile of abemaciclib. The most frequent adverse events of any grade were diarrhea, neutropenia, and fatigue in the abemaciclib group, and arthralgia, hot flush, and fatigue in the control. Serious adverse events occurred in 15.5% of patients receiving abemaciclib plus endocrine therapy versus 9.1% in those receiving endocrine therapy alone. Discontinuation due to adverse events occurred in 6.4% of patients in the abemaciclib group and 1.1% of patients in the control group. To manage adverse events, dose reductions occurred in 43.6% of patients. These were generally related to diarrhea, neutropenia, or fatigue. The role of Ki-67 in treatment decisions differs across countries. The FDA originally approved adjuvant abemaciclib for patients with HER2-negative, node-positive disease with a high risk of recurrence and a Ki-67 index of 20% or higher. The EMA took a different approach, approving adjuvant abemaciclib based on the monarchE intent to treat population, that is node-positive disease with a high risk of recurrence. It's therefore important that we resolve this issue. In monarchE, Ki-67 was determined centrally using an investigational Ki-67 immunohistochemistry assay performed on formally fixed paraffin-embedded tissue. A cutoff of 20% was used to define a high Ki-67 index. When IDFS results were split by low and high Ki-67 index, similar sizes of the relative effect of abemaciclib treatment were observed in patients with Ki-67 low and Ki-67 high tumors, suggesting that abemaciclib benefit occurs regardless of Ki-67 index. Thus, Ki-67 is not predictive for abemaciclib benefit. In light of this follow-up data, which also included the updated overall survival analysis, the FDA has expanded the abemaciclib indication to remove the Ki-67 testing requirement. We know that premenopausal patients with hormone receptor positive HER2-negative tumors may have a different, more aggressive tumor biology and therefore a different treatment response compared to postmenopausal patients. The overall incidence of premenopausal patients differs between regions and is, for example, higher in Asia than in Europe or the US. Dr. Palub Shimon and her colleagues therefore investigated the benefit of abemaciclib in premenopausal patients in the monarchE trial. Of the 5,637 patients enrolled in monarchE, 43.5% were premenopausal and the remainders were postmenopausal. In premenopausal patients, abemaciclib plus endocrine therapy demonstrated a 42.2% reduction in the risk of developing an IDFS event compared to endocrine therapy alone. In terms of the Kaplan-Meier plots, IDFS rates at 3 years reflected an absolute difference of 5.6%, with 89.5% in the abemaciclib group versus 83.8% in the control group. These figures were similar to the postmenopausal group, with IDFS rates of 88.2% in the abemaciclib group versus 83.1% in the control group. The safety profile outcomes were similar to those already reported. However, venous thromboembolic events were more frequent among premenopausal patients in the abemaciclib group than among those in the endocrine therapy group alone. The optimal duration of therapy remains unclear. It was investigated for 2 years in monarchE, but in NATALY, adjuvant CDK4/6 inhibitor therapy with ribociclib was given for 3 years. Further biomarkers predictive of response to adjuvant CDK4/6 inhibitors are currently still being investigated. Whether adjuvant CDK4/6 inhibitor therapy can replace chemotherapy in early breast cancer, that is hormone receptor positive, HER2-negative, remains to be seen. monarchE and NATALY are unable to answer this question because about 90% of the patients had prior chemotherapy. The WSG ADAPT cycle study, which has already been fully recruited with over 5,000 patients screened and almost 1,700 patients randomized, will provide an answer to this question in about 2 to 3 years. To answer this, let's look at example patients. all with hormone receptor positive, HER2-negative early breast cancer. Sophia is a 64-year-old postmenopausal patient. She has a grade 2 tumor and 4 of 4 lymph nodes are positive. Her Ki67 is 10%. The question we may ask is whether Sophia's eligibility for abemaciclib has changed in the light of the recent follow-up data. The answer is yes. She is at high risk due to the 4 positive lymph nodes, so this alone makes her a candidate for treatment with adjuvant abemaciclib. Beatrice is a 53-year-old postmenopausal patient. She has a grade 2 tumor and 3 out of 3 lymph nodes are positive. Her Ki67 is 15%. This patient doesn't meet high-risk status according to monarchE, so the question here is whether there is any more that can be done. For local control, Beatrice will need an axillary dissection in order to evaluate the true nodal status because all of her dissected lymph nodes so far have been tumor-involved. It may also be advisable to retest her Ki67 as there could well be hotspots with higher proliferation in the tumor. Kim is a 46-year-old patient. She is premenopausal with a grade 2 tumor as well as 2 out of 4 positive lymph nodes and a Ki67 of 25%. This patient isn't at high risk clinically, so does she still meet the criteria for abemaciclib? The answer is yes. In this case, it is via her testing for Ki67, which is greater than 20%. Follow-up data for abemaciclib also confirms efficacy in premenopausal women. Thank you all for listening to this overview of the follow-up data of CDK4/6 inhibitors in early breast cancer. I hope you will find this useful when incorporating the data into your daily clinical practice.